సార్.
ఎస్ శేఖర్ సార్.
ఓకే ఓకే సార్. ఇంకా ఎవరున్నారు? అవునా? ఓకే.
మన పిఎస్ఎన్ మూర్తి సార్కి పంపించారా ఈ లింక్?
పంపించాను.
ఓకే, మన స్పీకర్
స్పీకర్ కూడా పంపించాను.
లాగిన్ అయినట్లేరు కదా?
మ్హూ.
హలో, యా, participants have logged in on the other website.
సార్ ఆనంద్ సార్ వినిపిస్తుందా?
వినబడుతుంది, మీరు
ఓకే.
మాట్లాడుతున్నది వినబడుతుంది.
యా.
నేను ఇంట్రడ్యూస్ చేయనా, బయోడేటా చెప్పానా?
మీరే చెప్పండి సార్.
ఇంకెవరైనా లాగిన్ అయ్యారా?
మ్,
నా వీడియో కనబడుతుందా అండి?
మీరు కనిపిస్తుంది.
Hello.
హలో సార్.
Yeah, hi.
గుడ్ ఈవినింగ్ డాక్టర్ సలబ్ శర్మ గారు.
Good evening. Good evening to you.
సార్ గుడ్ ఈవినింగ్ సార్. హలో సార్.
Good evening.
Sir, I am Dr. Shekhar Reddy, and
Yeah.
one more sir is there, Anandacharya sir. He is the secretary of
Good evening to all of you. We are having the sixth webinar on the ENT topic, which we have envisaged, and this is the sixth seminar. And this seminar, for this, we have invited Dr. Salabh Sharma from New Delhi. He will be talking to us on eustachian tube, tuboplasty, its indications, and the procedure. Dr. Salabh Sharma is a senior ENT consultant and cochlear implant surgeon at Sir Gangaram Hospital, New Delhi. He is a visiting consultant at Royal Bahrain Hospital. He received his MS ENT from KMC Manipal in 1994 and the DNB ENT in 1995. He was awarded the DLO RCS in 1996 from England and FRCS from Ireland in 1997. His interests are minimally invasive sinus surgery, cochlear implant surgery, and middle ear ossicular reconstruction. He has presented extensive experience with balloon sinuplasty since 2008, and he has performed more than 1,000 cochlear implants at Sir Gangaram Hospital. He lectures both nationally and internationally on sinusitis, balloon sinuplasty, and cochlear implants. And to his credit, his name has been included in the Limca Book of Records 2002 edition for a pioneering endoscopic surgery of a life-threatening nasal and sinus tumor. So I request Dr. Salabh Sharma to introduce the topic of balloon sinuplasty to the juniors and our colleagues for keeping our knowledge. Thank you, sir. Over to Dr. Salabh Sharma, sir.
Good evening.
Anand sir, we have a guest, PSN Murthy sir. Sir has also joined. I wholeheartedly welcome PSN Murthy sir for this webinar, sir.
Yes.
And Salabh sir is a student of Murthy sir during his Manipal days, sir. Thank you, sir.
Good evening,
Murthy,
Dr.
sir.
PSN Murthy, sir.
Yes, and I was a very lucky student to have him as my professor. I think he is the best teacher that I have ever come across during my entire career. And
Yes, sir.
I really owe a lot to Dr. Murthy, Dr. PSN Murthy, for all that he taught me and the confidence that he gave me. He used to stand unwashed and watch me do the thyroidectomy when I had just finished 1.5 years of my post-graduation. And that is the kind of confidence he gave me. So thank you for having him here. I'm going to speak to the audience regarding my experience with the balloon tuboplasty, eustachian tuboplasty. Is something that I've been doing for more than 10 years now. Initial years we were using the sinus balloon because there were no eustachian tube balloons available. But now with the eustachian tube balloons, I'm specifically using the balloons meant for eustachian tuboplasty. Even now there is a lot of difference in price and size of the devices. So I think the cheapest one or the simplest one is the manual device, which is the one that I'm using now. Okay. So the structure of the eustachian tube was explained or first listed by the anatomist Bartholomeus Eustachius in 1562. So it's been almost, I think, 450 years since he described it. This is basically, the tube is a conduit that goes from nasopharynx to middle cavity. We all know that. It measures about 31 to 38 mm. But some studies, I think in the Western population, is 40 mm plus minus 4 mm is the size. The medial part is cartilaginous, the outer part is the bony, the lateral part, and the portion of the lumen which is the cartilaginous, that is the one that is considered as the functional valve. And at rest, this valve is closed or should be closed and is opened by the actions of the associated muscles of swallowing. I think one thing that is important in this, and I'll talk to you about later also, is that the cartilaginous part, which is medially present and is longer than the bony part, where it connects with the bone, the isthmus, the area prior to that is also very important, and that is what also plays a role in the results of this balloon tuboplasty. The functions of the eustachian tube are the equalization of pressure between the middle ear and the external environment, drainage of mucociliary drainage of secretions from the middle ear going towards the nasopharynx, and protection of the middle ear from loud sounds and from pathogens or secretions that are in the nasopharynx. So the tube is there to open and close and to let air enter into the middle ear, but it is also there to prevent other substances like liquids from the nose or sinuses entering into the middle ear from the nasopharynx. And so eustachian tube dysfunction is caused when there is sorry, 1 second, I can't see this. Basically eustachian tube function is caused when the tube doesn't open properly and the pressure doesn't equalize. So what you get is the symptoms are ear fullness, pain, pressure, popping and crackling sounds, muffled or reduced hearing, tinnitus, ringing in the ears, dizziness or imbalance, or recurrent ear infections also. And the impact on hearing is because of the non-equalization of pressure, and this pressure can cause chronic discomfort to patients, and actually it can cause decreased quality of life. Both a blocked tube dysfunction or a patulous eustachian tube, both can cause a lot of effect on quality of life, and patients who come are very worried or they are very tense or anxious because of the chronic problem, and there doesn't seem to be any solution to it. And the importance of tuboplasty is that it's a very easy to do usually, unless you have a very badly deviated septum, though I can tell you later how to address that part. And basically you're trying to get the normal eustachian tube function back, and so that the patient's symptoms are alleviated. The eustachian tube dysfunction can be a mechanism for the development of middle ear disease, tympanic membrane retractions, otitis media with effusion, and chronic otitis media and adhesive otitis media. So what I'm saying is these are the effects of having eustachian tube dysfunction, and it is divided into two types. Acute eustachian tube dysfunction is transient, symptoms last for less than 3 months, while the chronic eustachian tube dysfunction is when it extends beyond 3 months. My interest in eustachian tuboplasty, to tell you the truth, is not related to otitis media with effusion or glue ear treatment. It is more related to tympanic membrane retractions, otitis media with effusion, which is chronic, and that causes a chronic adhesive otitis where the tympanic membrane is adhesive onto the promontory, onto the ossicles. And to treat those patients, which are very difficult, adhesive otitis usually has some of the worst results in terms of hearing results after ear surgery. Causes of eustachian tube dysfunction will be all the causes of allergic disease in the nose, laryngopharyngeal reflux. Very important to recognize LPR as a commoner than thought cause. It's more common than we think, and it's there even in children, and it's there in adults. So any person not responding to treatment, is better to try a longer, maybe a 3-week course of a PPI, so that we can see the effect of that. Sometimes that is what brings about an improvement. Then large adenoids, rhinosinusitis, mucosal disease like Samter's triad, immunodeficiency, environmental exposure, tobacco smoke, all of these things that affect the eustachian tube function or the mucosal clearance of the eustachian tube mucosa or the lining of the mucosa itself, and bulky tubal tonsil tissue and muscular dysfunction. So now in this, for example, if you have bulky tubal tonsil tissue, you don't have large tonsils, adenoids, then what do? You should use, with the coblation, remove the tubal tonsil tissue, just preserving the mucosa which is inside the opening of the tube of the eustachian tube, and the outside you can clear. And if you do that, then there is likely to be improvement. So in diagnosis, when we diagnose eustachian tube dysfunction, we are looking at oral fullness, increased pressure in the ear, which is very disturbing to patients, otalgia, sometimes with or without decreased hearing, but usually a muffling of the sound is there, muffling of voice. And otoscopy will show retraction of a tympanic membrane with maybe a middle ear effusion and a type C or a type B curve. The indications for a tuboplasty, what are my indications, are a little different. These are the standard ones. So chronic dysfunction, not responding to consent. So you've got a otitis media with effusion, fluid in the middle ear, glue ear, not responding. Instead of putting grommets, you can do eustachian tuboplasty, and within a few weeks you will see that it will resolve. Recurrent middle ear infections, hearing loss due to eustachian tube dysfunction, adhesive otitis media, and retraction pockets with cholesteatoma. So this is where I usually use most of my, where I do most of my balloon dilatations. Pre-op evaluation, audiometry, pure tone, tympanometry, and it says, for example, CT scan to visualize the tube anatomy, but I don't really get CT scans done for any patient if I'm planning to do. I would get a HRCT temporal bone if there is a cholesteatoma or a suspected cholesteatoma with a retraction pocket, but I wouldn't specifically get a CT scan to look at the eustachian tube. And evaluation of this is next. So the surgical techniques, described is the balloon dilatation, the easiest, laser-assisted eustachian tuboplasty. The results of balloon dilatation are as equal to or better than laser-assisted tuboplasty. And traditional approaches, of course, like a myringotomy and tube placement, which you can do for effusion, but has not really much role to play if you're reconstructing a ear with the adhesive tympanic membrane or a cholesteatoma. Indications of doing the balloon eustachian tuboplasty is any child above, from the age of 7 years onwards, and anyone who has these symptoms of the uncomfortable sensation of pressure, inability to perform Valsalva, chronic otitis media with effusion, middle ear adhesive otitis, perforation, cholesteatoma, failed tympanoplasty. The dilatation technique is that the balloon dilation is done under general anesthesia usually. If you have a deviated nasal septum to one side, then there will be a problem. So what I usually do is that if there is a deviated septum, say on the right side, and I am unable to go in with the endoscope and the catheter together, then what I usually do is I will take a 70D telescope and put it in the contralateral, the opposite nostril, opposite nose, go behind the nasopharynx, and from there look at the opposite side eustachian tube, and then through the side with the deviation I will pass the eustachian tube catheter, which usually you can manage under a spur or over a spur or some way, and is able to go. And the thing is, GA is that the patient is comfortable. Under local you can do it maybe. I've never done it under local because I would be a little worried about stimulation of maybe the vagal or some nerve. I'm not sure, but the patient would be much more comfortable always under GA. The balloon catheter is introduced into the eustachian tube via the nose, and once it's correctly positioned, so the most important thing is that when you take you have a guide catheter, which is a 55-degree usually guide catheter, which will go up to the point of the eustachian tube opening, which you can see here. This is a guide catheter. Through this you push the balloon and it goes up, but usually the angle has to be right. You have to do it pointing laterally and superiorly. So superolaterally like this, that is the direction in which it goes. And then once you insert the balloon, you extrude it. Once it reaches about 15 mm, 20 mm, or even about 14 to 15 mm, it will put back pressure and your catheter will then come out while the balloon will get longer, and you'll see the balloon here. I'll show it in the video. So the most important thing is to push it until that plastic tip of the catheter reaches the bony isthmus. At that time there will be a hard stop, and beyond that there is no need to push. Neither usually is it even possible to push. Even if you try, it will not go. But once you've reached the hard stop, you're already at the bony isthmus and you should stop pushing, and then you can start dilating. Before you dilate, of course, you have to make sure that your entire balloon is out of your catheter. If some part of the balloon is still inside the catheter and you dilate, then the catheter tip will blow up or the balloon will burst. How does balloon eustachian tuboplasty work? See, everyone must be thinking, how can such a thing work? Just dilating the cartilaginous part of the tube. How can it cause an improvement in eustachian tube function? It doesn't make, it's difficult to imagine. So they've done the studies, histopathological also, and this is what they've found. Basically, after the balloon eustachian tuboplasty, you are left with a wider opening of the eustachian tube. Visibly also, it becomes larger, number one. Secondly, there is a crush injury that is caused to what is the abnormal lining, eustachian tube lining, because in chronic otitis media effusion long-standing, the eustachian tube mucosa is no more normal mucosa pseudostratified. It has changed, and it gets crushed by the balloon, and then when it recovers, it is seen to recover with normal, healthy pseudostratified epithelium. Healthier lining also secretes more surfactant. So surfactant is one thing which is a substance which is produced by the lining, not only in the lungs but also in the eustachian tube, which reduces surface tension and acts as an anti-adhesive. And this production is less when the mucosa is diseased, and it improves after the mucosa recovers. Cracks appear in the region of the eustachian tube, which is rich in elastin fibers. This they have done the pathological studies, and this is the area that acts as a hinge during opening just prior to the bony isthmus, right? So the end of the cartilaginous tube, when you insert the balloon, the last part when it touches it's near the area where the elastin fibers are maximum. Recovery in a effusion can take up to 6 to 8 weeks. But if we are doing a adhesive otitis surgery or a tympanoplasty mastectomy, then recovery can be earlier. I'm just going to go through some case histories. I have a patient, LG, he's a male patient. He had a decreased in hearing and itching in the left ear and nose blockage. Ears had otomycosis. We cleaned that. The tympanic membrane was a grade 3 retraction adherent to the ossicles, but the ossicles seemed intact. In the posterior superior quadrant, there was where the retraction was. Severe deviated nasal septum, bilateral inferior turbinate hypertrophy, bilateral large middle turbinates, and enlarged adenoids. And CT scan showed DNS to the left, bilateral inferior turbinate hypertrophy, enlarged adenoids, and also I think a bilateral concha bullosa. So there was a left posterior superior quadrant retraction pocket with epithelial flakes in this patient. Left side at 25 dB airborne gap, deviation of the septum, large turbinate adenoid, paradoxical middle turbinate, and a spur to the right. So what did we do? This is a photo taken in the OPD. It's not very clear, but it was taken after the otomycosis was removed in the pre-op stage. And then what was the plan? So actually I planned 2 surgeries for him. The first was reduce the inferior turbinates with copulation, do a copulation adenoidectomy, do a left balloon eustachian tuboplasty, do a septoplasty, and this I performed on June 2023. I had planned that as a second stage, after a few months, when all of this had healed and the tube function was better, I would do repeat the left balloon eustachian tuboplasty, because if I'm putting the patient on general anesthetic twice, I might as well do the tuboplasty twice. It can only bring better function. And the other thing is I was planning at that time to do the mastoid exploration for the left ear with the posterior superior quadrant retraction pocket and adherent to the ossicles, and do a tympanoplasty if required, if there was a dehiscence of the ossicles, ossicoplasty, otherwise that would not be required. But what happened is that this is the post-op photo of the same patient after the balloon eustachian tuboplasty was done, and this is the PSQ area, which you can see that the lining is, the tympanic membrane is not intact, and there seems to be like a dehiscence here. This is after the tuboplasty. This is the same patient of the ear in December 23, 6 months after I did the tuboplasty in that ear. So when he came to me on December, I said, okay, now let's get ready for the ear surgery. I'm planning the surgery in the next 1 week, and let's get your otoscopy done and your hearing test done. But this is what we found. The eardrum has healed. Now, no need for any surgery. So this patient, for some reason, the balloon tuboplasty and the nasal septal correction and adenoid correction and all of that was enough to cause that retraction pocket to become normal, to disappear, and for the eardrum to actually be normal. And this is without any ear surgery. I think congestion that you see is a little bit because I think wax was removed just prior to the photo getting taken. This is another patient. He's a 48-year-old male. He's a kidney transplant patient done 5 years ago, and recently a history of being treated for TB of the appendix. So in left ear, he came with the discharge, itching and pain for a few months. So on otoendoscopy, we found a PSQ retraction pocket. And what I told him was, I'm going to do a left tympanoplasty and maybe a little bit of inside-out mastectomy to make sure that I am able to get the entire pocket out, and then also a tuboplasty at the same time for the balloon for the eustachian tube. This was my plan. So balloon tuboplasty first, followed by a little bit of inside-out mastectomy to get to the bottom of the pocket to make sure there is no, to get the entire retraction pocket out, and then reconstruct maybe with a little bit of cartilage in this area. That was my plan. What happened is that this is the pre-op photograph of the PSQ retraction pocket. I don't have a better photo, but it was a much deeper pocket. here. If you go in with a 70-degree telescope or 45-degree, you could see a deeper pocket in the PSK. This is the posterior superior quadrant. This is the surgical video. You can see I am following the balloon 55-degree angled catheter with my endoscope. So both going together. I was talking about the angle. See, the eustachian tube is not like this. It is like this. So you get the angle right, and you can see I am extruding the balloon. The balloon is coming out here. You can see this black mark. It tells you that now the balloon is out of the. If the black mark comes till the tip, that means the entire balloon is out, and no part of the balloon is inside this. Otherwise, this plastic will crack and break if you dilate the balloon before it extrudes completely. Now you can see the balloon has enlarged. Here's the balloon going up inside, and I am using the catheter to hold it in place to prevent it from coming out, because when it expands, the eustachian catheter has a tendency to come out of the, and you can see now the eustachian tube, you can see very nicely a wide opening of the eustachian tube. You can see I'm just taking out the balloon slowly. And look at this. So what happened is that this was the retraction pocket here. This is the posterior superior, posterior inferior quadrant. There was a pouch here inside like this, in this area. And because of the increased pressure from the balloon, the entire retraction pocket prolapsed out into the middle ear, making my job very easy. So I did not need to remove any bone here to work on the middle ear. The entire pocket was extruded in one piece. So all I had to do was excise it. And reconstruct. So this is what I did. No ossiculoplasty required and no bone drilling required. So what I did was I cut 2 strips of cartilage, and I placed the 2 strips of cartilage in the posterior superior and posterior inferior quadrant area under the tympanic membrane. And I put a graft, and that's it. These are now 2 thin strips of cartilage, about maybe 4 or 5 mm length. I used a suction to get it in place. It took me a couple of minutes to get it to sit right, but so I did it transcanal. Now there's another patient. He was, let me just go through this again. So he's a patient SA. He had left ear attic erosion with addition of the tympanic membrane with cholesteatoma flix. And he underwent a left canal wall down mastectomy, a tympanoplasty, osteoplasty, septoplasty, bilateral eustachian tuboplasty, and also a coblation assisted inferior turbinate reduction. So I do not stage my surgeries usually. Unless there is a big problem, I usually do my nose and ear at the same time. And so if you see what did I do here, after the tuboplasty was done and the nose was done, then went to the ear. And you can see here that, one second, mastectomy up to the mastoid cavity, malleus remnant and necrosed remnant of the incus were removed. Stapes footplate was intact, but the remnant of only the posterior crus was present. Anterior crus was dehiscent, it was absent. So cartilage was harvested, and a boomerang shaped cartilage, or a sort of an L shaped cartilage, where the short L part goes into on the footplate and the long L goes towards the hypotympanum antero-inferiorly. And that's what I do for reconstructions. And because these are all adhesive otitis media patients, it is not really worthwhile trying to put titanium prosthesis, torp and pops. I used to do that a lot maybe 15, 20 years ago, but after some time, after 2, 3, 4 years, invariably because of the further retraction, it extrudes. So in a patient with adhesive otitis, I would only reconstruct with cartilage usually. This is the same patient's pre-op photograph showing the erosion posterior superior quadrant and going posteriorly. And this is now today's, actually he came today, so this is today's photograph with the healed tympanic membrane and the cartilage that I have placed in the attic and in the posterior area. And this is his pre-op audiogram. You can see pre-op, he had a pretty large, I think 50 dB gap, 40 to 55 dB gap. And now if you can see, it's like a 15 to 15 to 30 dB gap. So earlier he was at about 60 decibel hearing. Now he's at about 35 decibel hearing. So that I think is a good, I consider that a decent improvement. I'd be happier with 10 dB more improvement, but I think in a patient who has only the posterior crura present of the stapes, getting a very good palatable cartilage is not so easy. And probably if he had the anterior crura also, I could have got a slightly better hearing result. And these kind of results are very difficult in adhesive otitis media or these cholesteatoma patients if the eustachian tube doesn't function after the surgery, because the effusion stays, conductive deafness persists, and the patients are pretty unhappy with the results. There are so many papers on eustachian tuboplasty, but this one is a nice one because they did it on 126 children and they found that it improved the hearing in 76.5% of children. But again, this is now, we're talking about glue ear. Okay, this is not my principal cohort of patients which I do. This is not my principal. But if you ask me about side effects, the children, they had some mild epistaxis, some post-op pain. 3 children developed otitis media, and balloon dilatation had to be repeated in 9 of 34 patients. But in my experience, I've never seen side effects per se. If there is a little bit of bleeding, it takes place the same time when you remove the catheter, but it doesn't really take place in the post-op period. And I had one patient recently, I've been doing it for so many years. I had one patient recently in whom I have already done 1 year bilateral eustachian tuboplasty, 1 year reconstructed. This time I reconstructed the other ear. When I did this year, I did the balloon again for both sides, trying to improve function. So after that, he developed a effusion in the previously operated and better hearing ear. So for about 2-3 weeks, his hearing came down, some conductive loss because of fluid in the good ear. So he was a bit worried, but now he has recovered. And the other ear has also started showing good hearing improvement. If you see this study, it shows that 80% reported long-term reduction of symptoms, but this is for eustachian tube dysfunction where we are looking at oral fullness, otalgia, recurrent otitis media or effusion, and then seeing the results after that. And there's another study which looked at eustachian tuboplasty alone, BET alone, or with or myringotomy in the eustachian tube dysfunction. Adding myringotomy did not further improve the outcomes over BET alone. So this clearly tells you that no matter what you do with you are able to achieve as good results with the balloon eustachian tuboplasty as you can get by doing the myringotomy. And this is an analysis which compared eustachian tuboplasty with the balloon and laser assisted eustachian tuboplasty, and they found that the laser tuboplasty results, the balloon tuboplasty results were as good or better than the ones with the laser tuboplasty. And the Valsalva maneuver improvement rate was better in balloon tuboplasty, 67% versus 50% for the laser tuboplasty. There are risks associated: mucosal lacerations, false passage, introduction of air like emphysema into the surgical into the tissue, migration towards the internal carotid, occlusion of the lumen of the catheter, submucosal emphysema, or patulous eustachian. So I'll go through mucosal lacerations. If you are careful, the most important thing is when you put the balloon in, you have to be very steady with the catheter, that when you inflate the balloon to 10 atmospheres and then you have to wait for 2 minutes by the clock before you deflate the balloon again. So when you do that, you should not allow the balloon to move in and out of the eustachian tube. If you allow the balloon to expand and then you allow it to move out, that can shear damage, cause shearing damage on the mucosa. So you make sure that your eustachian catheter, like you saw what I was doing, holding it tightly against the end and making sure that it doesn't slip out. There is no movement in and out when the balloon is already dilated. Number one. Then introduction of air, unless you allow a big laceration to take place, this will never happen. So again, the same principle, don't allow the balloon to move, hold it steady with your catheter and until the 2 minutes are up. Then migration of towards the internal carotid. Internal carotid artery, even if it is dehiscent, unless there is an abnormal artery, the maximum that will happen is that the balloon will dilate the cartilage and it may compress that. So you should always be watchful for any bradycardia that you may see during the procedure, but I have never had a problem. Secondly, when you insert the balloon through the catheter, guide catheter, and it goes in and it touches the bony isthmus and it stops, there is a hard stop, you can't push it anymore, then you know that you are in the right place, there is no problem. If you ever insert a balloon catheter and it just keeps on going in after 15 mm, 20 mm, then you should stop and think maybe there is a problem and reevaluate what you are going to do. That has never happened with me yet. I have never faced that problem. And occlusion of the lumen of this is an important thing with any balloon. If you inflate with saline and for some reason the exit gets blocked, then the balloon will remain inflated inside. And if that happens, then you should try to get a long needle or something and puncture the balloon so that the fluid can release. And that it's never happened to me, but this is something any person who uses a balloon should be aware that this may happen at some time. And submucosal emphysema, I have never seen. Patulous eustachian tube dysfunction after, I have not seen. I have never had a patient complain of that. Thank you.
Anand sir. Hello.
Hello,
Anand
sir. Sir, Dr. Sharma, sir, thank you very much for your elaborate discussion on this topic. You have introduced this topic, which is a fascinating development in otology.
Thank you.
Sir, few questions we can ask.
Sure.
Sir, in all retraction cases, do you recommend initial balloon this tuboplasty?
Yeah, I'm doing it for all balloon, all retractions, all cholesteatomas.
It is mandated that we do this and
It's not
then go on.
mandatory, and I cannot speak with this thing, but my experience with because I have been doing this adhesive otitis media for many years now, right from beginning of practice.
Yeah.
And initial results with the tympanic membrane retracting again was almost invariable in like a large percentage of cases. What I used to do is layer the middle ear with cartilage to prevent further retraction, but you could make out later that there was not much air in the middle ear and the tympanic membrane was adherent to the cartilage under it, and that was sitting right on the promontory wall. And hearing results also used to have a 35-40 dB gap usually, and and if I use the prosthesis like I using the Kurz prosthesis, I used to use a lot of Kurz. The Kurz prosthesis, the titanium prosthesis from Germany, the tops and the pops, and now I use maybe 3-4 in a year, only when I think it's really suitable. Otherwise, I'm always using cartilage because in adhesive otitis and even in some cholesteatoma cases, which are posterior superior quadrant retraction or aortic retractions, the eustachian tube dysfunction persists and the patient after a few years develops retraction again, and then because your ossicle which you have put, the top is one of the higher points in the tympanic membrane, then the tympanic membrane gets adhesive and then finally it comes out. So the top or the port gets extruded. So I have stopped using them.
Sir, in a case of recurrent otitis media acute, which has recovered, do you offer balloon tuboplasty as a treatment?
No, if the patient recovers, I would not do a balloon. If the patient recovers medically, and medically means you have to treat if any underlying infection is there, like sinusitis, you have to treat that. If there is an infected adenoid, because sometimes you may have it may not be a large adenoid, but may be infected, which when you do an endoscopy, even in children, as young as 6 or 7, we do a nasal endoscopy and we can see the adenoid. Unless there is if there's an infected adenoid, then treat that. And then if it's resistant, especially in the elderly or even adults, or even sometimes in children, I give a little bit of oral steroid. And in almost most of the patients, they improve. So in my practice, actually, to tell you the truth, grommet insertions are very rare. I mean, they're there, but not much. Because most of the time I'm able to medically improve them with medication. I think controlling laryngopharyngeal reflux, some dose of steroid to decrease the inflammation around the eustachian tube opening area or the adenoid area or the sinusitis, that helps along with the rest of the medicine. Nasal decongestant, drops, steam inhalation, some sprays, of course, like everyone else. But these are what I add, and most of the time I'm able to get the patients off the means they are able to. I'm able to cure them without the need for doing any procedure.
Sir, any experience with post-radiotherapy eustachian tube obstruction?
Sorry, what is that? I'm not familiar with that.
Post-radiotherapy eustachian tube obstruction, do you have any experience?
No, I don't have any experience. But if you can see on a nasal endoscopy, if you can examine the eustachian tube opening and the torus, and if you find that it is not severely fibrosed, right? If there is fibrosis but not very severe, like complete stenosis is, in fact, there was one patient. But if it is not totally stenosed and you have an opening, then you can put in a balloon and dilate it. There's no reason to think you can do a balloon dilatation there. But there, because the balloons are 14 mm length and the thickness can be 5 mm, 6 mm. So I would say go for the the shorter diameter balloon if you can. 4 mm or 5 mm balloon if you can use, that will be best. Because if there is fibrosis, then you don't really want to open it so much that you cause extensive fibrous tearing. So just do enough to get a good dilatation and try to get it back to normal. There is one case, I think, if I'm not mistaken, where the tube was scarred. I'm not sure, radiotherapy or I'm not really sure. Maybe post-adenoidectomy, very badly scarred both sides. And but the opening was present, so I did the balloon dilatation, and that patient also improved. So you can use it for radiation also, I'm sure, but just don't over dilate. Try to get it, because the balloon is such that if it's a 6 mm balloon or a 5 mm balloon, it will increase to that size. If you put less pressure also, it will still go to 6 mm. So the thing is, you cannot use a balloon as a variable balloon key. If I put less pressure, it will be 4 mm, but if I increase it, it will become the 6. No, it will become 6. So you should go with a 4 mm balloon. No matter what pressure, how much pressure you put, it will not increase beyond 4 mm. 4 or 5, yeah.
What are the steps to establish a balloon sinuplastic clinic, sir? Eustachian tuboplastic clinic, steps. What all you need?
Actually, nothing, just a nasal endoscope, just a routine nasal endoscope, so you can examine. And of course, preferably under general anesthetic, but if you're doing only a balloon, it will take about 10 minutes to do both the sides. Very short anesthetic. And that's why I find that I don't like to use a balloon, because I have to give a general anesthetic to patients who have just something like a glue ear. I would rather try and get them better. In this 2024, I have only used the myringotomy and grommet in one adult patient.
Sir, I heard Dr. P.S.N. Murthy telling once that we can use the angioplasty balloons also for tuboplasty. If Dr. P.S.N. Murthy is on the line, I request him to ask that question.
You can use any balloon which will dilate cardiac catheters also up to that size, but just the eustachian tube balloon is perfect size, like 14 mm, and it's designed just for the eustachian tube. And it is, I think, I don't know about, it's not very expensive. The hospital cost towards the patient, I think, is 18,000 rupees. But I'm sure the hospital gets it much cheaper, and I'm sure that as a private practitioner, if you negotiate with the company, you can get it at a good rate, without much problem. And patients and insurance is ready to pay for this thing. Insurance, I've never had a problem with insurance. They pay for the balloons.
Dr. Shekhar Reddy, you have any
Anand,
Sir.
questions?
Anand, can I ask you a question?
Yes,
Sir,
yes, yes,
sir.
sir.
Good evening, sir.
Good evening, sir.
Shall I
Yes, sir.
do one is a question and one is a comment. I've been doing balloon dilatation using a cardiac balloons.
Yeah,
I mean, they're freely available because they throw it off
yeah, they
once
throw
they
it
use
away.
it. Anyway they are going to throw them out. So I just tried with that. I mean, that is a few cases. I'm not. No, I'm just thinking. Did you ever try a reverse balloon?
Which balloon?
Reverse balloon dilatation. I mean, in the sense you have a perforation. Why, why don't you try to do a reverse balloon dilatation through the eustachian tubal opening in the middle ear?
No, sir,
I mean,
because that
maybe
is
because you're doing a lot of cholesteatomas and these cases also, you can try that. At least will you don't need to enter into the nose. You can if you can do the procedure from the middle ear.
so
Yeah, I'm just thinking aloud.
that will be because that will be the bony eustachian tube, and we don't really want to crack the bone there. That's very hard bone, and then the
No,
carotid artery is
you
adjacent.
have to cross across the isthmus and enter into the cartilage.
The isthmus is very narrow, sir. I think once you reach the bony, once you put it into the bony eustachian tube, it will come to the isthmus and it will again stop. It will not cross over.
Anyway, just a thought. Try it out and see. You can do that.
Yes.
I'm so proud of you, Salam.
Thank you, sir.
So happy, so happy. I just
So
wanted
proud
to
to be
be.
here while you are also on the platform. Thank you.
Thank
Sir,
you.
one question.
Thanks, Anand and Shekhar. Thank you for giving me
Thank you,
this
sir.
opportunity.
Thank you, Murthy, sir.
Thank you, Murthy, sir. Thank you, Murthy, sir.
Sir, in allergic rhinitis patient, does a balloon tuboplasty offer any additional advantage? Recurrent allergy, recurrent eustachian tube block, allergic rhinitis patients.
It will work in allergic cases also because it actually they've shown it histopathologically to improve or to reset the lining of the eustachian tube. In long-standing allergic rhinitis, the lining of the eustachian tube, the mucosal lining changes, and it's not the usual pseudo-stratified. And there are more goblets, there's more inflammatory cells, chronic inflammatory cells also, allergic inflammatory cells also in the lining. By crushing it, when you crush it, what they found is when it heals with normal lining. So that will really help.
Okay, sir. Anand, sir. Anything else?
No questions from my side, sir.
Okay. Actually, Sarab, sir, so many audience are there, but very few people can speak. For remaining, all of them, we have given other links, sir.
Okay.
You know. Sir, on behalf of AY Telangana, I really am very thankful for this webinar, sir. Anand, sir, actually, since 1 month I am trying. It is
Sir,
very
sir.
difficult to get appointment of Salab, sir. Very, very, very difficult. Very difficult.
Yeah,
He is such a busy surgeon.
yes.
So I was trying since 1 month. After that, I got because this is a good topic. So many postgraduates they have insisted me on this. Kindly throw some light on this eustachian tube disorders and all.
So we are
Shekhar,
thank you, sir.
Shekhar, he
Yes,
does
yes, sir.
lot of balloon sinoplasty.
Yes, 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 yes.
Actually, you can ask him to talk on balloon sinoplasty because he does
Yes,
a
sir.
lot of balloon sinoplasties.
Yes, sir.
Can we fix up another webinar, sir, for that?
Yes,
separate
yes, yes,
topic?
definitely. Sir,
Provided Dr. Salab is free.
Done.
yes. Sir, Salib sir, in the month of October 18th, 19th, 20, we are hosting a South Zone ENT conference in
Yeah.
Hyderabad, sir. Shortly, we will send answer.
Yes, sir.
Yeah.
We will
Yeah.
send a request. We'll send a request to Dr. Salab and we'll see. We'll invite him for a talk.
I'll
Yes,
be
sir.
there. Sure.
So
Sir, shall we close, sir?
Yeah.
thank you very much. Thank you very much.
Thank you, sir. Thank you once
everyone.
again for giving us this opportunity, sir. Thank you, sir.
Thank you. Thank you.